Good morning, everyone. We're just going to start our deteriorating patient breakout session. So we're going to have a hybrid session going on between everyone here in the room. We've also got a large online community as well. We'll be involved in our discussion. I'm Lindsay Fielding. I'm one of the consultant geriatricians in NHS North Valley. I'm currently in the clinical lead at the deteriorating patient programme. So just going through the breakout session, I'm going to hand you over to the NHS Jubilee team who are going to be talking about their game changers. This session is about finding your game changers and it should be interactive. So hopefully you're not all sitting with your own health board, but if you are, maybe later we can mix up a little bit. We're going to have Julie and Gregor and Leslie leading that session, followed by some Q&A. And then some breakout sessions on what your game changers are in your hospitals and health boards. And then we'll come back together again at the end to discuss what we can do. So the aims of this session are to hear about NHS Lothian's work, think about your game changers, and then what's going to happen after this.
Lindsay. My name is Greg Neal. I'm an IC consultant in NHS Lothian, and I'm the deteriorating patient clinical lead for NHS Lothian as well. And I'm going to start off this kind of brief summary before we get into the activity. And the work we're about to talk about, I have probably contributed least to. So I get to describe the problem at the start, and then others are going to come and talk about how we fixed it. But we're really going to focus on the need for improvement. What was the problem we were looking at? What we built in NHS Lothian and how we built it and how we learned as we went along and where we plan to go next for this piece of work. And we hope that we're going to be really talking about an electronic observation system. But you can think about what we did and apply that to a problem in your own area. And it may be a similar one, it may be a different issue relating to patient deterioration. So the need for a new system. We've all been working really since 2021 and well before about the issues with the deteriorating patients, the recognition of a deteriorating patient, and also the response to the deteriorating patient. We published these reports in NHS Lothian that we sent to all our teams on a regular basis, and it showed that there were issues with certainly the response to deterioration, future care planning around deterioration, but also, most importantly, the recognition of the deteriorating patient. And we knew that had been a problem for a long time. I put this slide up, the signed guidance care of deteriorating patients, partially because it's a piece of work I was involved with, but I suppose even though that only came out in June of last year, it really summarised a lot of the work, a lot of the issues we had in healthcare since the first iteration of the deteriorating patient guideline had been published in 2014. And what it called out was a need for a change strategy around the recognition of deterioration. And it called out what evidence there was and what consensus statements we had to come to was that we needed an electronic system to recognise deterioration, an electronic system to collect observations, display observations, and share that observation data. And in our own health board in NHS Lothian, what were the issues with electronic observations, or what were the issues within observations? We knew that when we looked at a patient deterioration story, often obs were inaccurately recorded. And you've seen this in your own work, I'm sure, that as the patient deteriorates more, the attempt to take obs gets almost more and more frantic, and the errors come in more and more. And it was very common for us to say when we did a conclusion to a serious adverse events analysis that the observations were recorded incorrectly, they were missed, they weren't documented reliably. We have a thing in Lothian, you may have something similar, that if we're happy for a patient's OBS frequency or escalation plan to be changed from the norm, we term that special instructions. And often we found those special instructions were not completed. And beyond that individual patient, we had a lack of oversight of where our patients with our high needs were in our organisation. On each of our 3 acute sites, we didn't know where they were. And we wanted to change that. And really that's primarily what the problem is, and you can well imagine it in your own health board. What we did to change the system, I'm going to hand over to my colleagues who've actually done the heavy lifting in this project, led by our acute services nursing director, Julie McCauley. So I'll hand over to Julie.
Thanks. So our journey started in 2020. I had moved over to Lothian in 2019, and first stop for me was I want patient track in NHS Lothian, because at that point I had just come from Lanarkshire and they were just implementing it there. So I went to the eHealth director and said, could we have money to test patient track, which was a system that we would buy in to deliver electronic observations. Could I have money to test it in 4 wards? And he said, you absolutely can't. So that was stage 1. I thought, right, okay. But what you can have is, I will give you resource from the eHealth team, and we will build for you 80% of what you need in track. And I walked away from that conversation thinking, absolutely no way will they be able to do that. However, I've ate humble pie many, many times in that journey and said they've exceeded all of the expectations. So we met every week for 2 weeks, and we still do this every week. Every 2 weeks we meet as a group. The team started off with 2 parts to the project, where we would develop person-centred care plans, and then we would develop the news on track. The person-centred care plans were built first, and they were launched in 2021. So we just took a year to develop that, and then we focused on the news part of it. So we designed it on track ourselves. We developed obviously the software and everything that would go with that on track, and we are in a slightly unique position that we do have the opportunities to take track in Lothian a bit further maybe than other boards. We then developed an implementation plan, and we started off in our community hospitals simply because it felt a bit safer. The amount of observations that were being done on a daily basis, it just felt a bit safer to do that. We went into the mental health, and then out into acute, and we've got hospital at home, we've got everything all as part of that. Now, interestingly, from a mental health point of view, they've seen that some of the community sites were doing observations, and they just decided that they would do the observations as well. So for that, it taught us just how easy the system was to work as well. We had to do a wee bit of scoping around hardware and testing, and I'll speak about that a bit later on. And then we constantly reviewed. I think the most important thing for me was not to jump to the solution. So I was coming looking for the patient track as the end product, and actually I had to stop myself all the time and say, let's not do that, let's really design something that's bespoke for us. And now we, post-implementation, we just look through our software updates. So it's integrated to the electronic patient records. So in Lothian we use track for all our patient records. Our care planning system, everything is on track. There is no paper at all, and in fact the news was the kind of last bit of paper that we have moved off of. And you can see there that there's a data entry screen. The news reflects the current functionality, and that was something that we were really focused in on as we were developing this, that every functionality that we had on our paper chart, we replicated that into track. So you can just see there at a glance. I can't tell you how excited we were the day that the e-health team showed us the news chart that they could produce for us, because it is so like, as you can see, the paper one. And we went away from there. I mean, I went away definitely eating a humble pie that day around where my journey started and where we ended up. We also built into the system an escalation process. And any patient with a news of 5, there's a whole system then kicks in around escalation. Those escalations are then documented into the patient's notes, and the response, etc., is also documented. That probably for us was the biggest change, because that was a big unknown on a paper system, because frequently we wouldn't have escalations recorded and we wouldn't have the outcomes and updates from that. So that was probably culturally the biggest change for us. And you can see there it's who's been escalated to, time, and then it transfers automatically into the clinical notes. We've got visual prompts within our track floor plan. So there's a couple of things on here. So the patient's actual news score is on the track floor plan. There is a symbol, the disc with the red disc with the arrow means the patient requires escalation. So that's basing that on the news. So that's all automated. And then the grey one in the other box is just the patient has been escalated and that's been dealt with, and that's been signed off. And then the arrow, the up and down arrow, so the green arrow just in the bottom box there is to say that that patient's news score has reduced since the previous recording. So it lets you see when the news has gone up, for the red arrow going up the way, and then the green arrow when it's going down. We were really keen that we had as many visual prompts as we possibly could for teams who are working in very busy clinical areas. The wee bell is an indication that observations are due. So observational frequency is added into built into the system at the time of admission or wherever the patient is in their journey, and then that frequency is picked up by track, and we get an alert to say that the patient's observations are overdue that frequency. And we have added in a period of grace around that just to make sure that they are right. Gregor spoke about that overview, and the overview board has been really important to us, again, telling us what the patient's news score, and we can sort this by highest and lowest, and also whether that news has changed, if the patient has been escalated, if they've got a treatment escalation plan, so all the information is there. And this has been particularly a game changer for Gregor and his team from a critical care point of view around just scoping out who the sick patients are at the hospital. We've had a lot of work to do around governance and making sure that this automated system was safe, and hence the reason why we started from that community point of view. We are relying on the track system doing a lot for us, and therefore we had to make sure that it was safe. We had this multi-professional team. I actually wish some of the e-health team were here today. I can't begin to tell you how different a language they now talk being on this journey. They have been an incredible support for us. They've been in the wards on the Go Live days. They've supported, they provide reports for us, and any changes as we've gone along that we've needed made, they've been there to do. And as I say, the language they now talk, they talk about SPO2s, and it's just incredible the journey that they've been on as well. And we obviously have developed that measurement plan. So what's the impact of this? And we've got all the governance routes for reporting that up through. So testing was absolutely critical. We used quality management approach. We had a problem, we'd had a quality planning improvement, and then our quality control. So really testing it and using different. So we used simulation to just test that kind of initial. We've used simulation to test iPads, handheld devices. Believe it or not, we've opted for computers and wheels because everybody finds it's much easier to see the full chart. We had ward-based simulations. We got onto a pickle at one point where we had a really sick patient scenario and people just left the computer and went to their bits of paper and done all that. So just understanding the psychology and the human factors bit of that was massive for us in that testing. And again, we just tested across our whole system with all the different grades and staff. We've developed training materials, absolutely. There was less required for us around the actual input of the information. A lot of the teams, because they were using care planning, because they were using track, that didn't feel such a difficult thing, and it is quite intuitive, so it's quite easy to walk your way through. The bit of the training was the whole bit about escalation, the recording of special instructions, the news frequency, and going back to those principles about what a shock was for news. So we launched in August, still during COVID, in East Lothian Community Hospital, and then we rolled out the community hospitals, mental health and acute. And today we are on week 2 of the Western General Hospital rollout, and that will complete the rollout across every acute area, every mental health area and patients, and every community hospital in Lothian. We've got to double back to go into ED, and we plan to do that after the Western, and we've now got a short life working group for the Children's Hospital because we're developing pews on track as well, so that we've got all of it consistent. Emma, I'll hand over to you.
Thank you, Gillian. So to really summarise what we learned through lots of these challenges, we built this amazing system in Lothian. It's about how we actually practically use it. We have had lots of learning throughout it, and that 2-weekly meeting that Gillian's spoken about already is a really helpful docking place for all of those lessons to be learned, for them to be accounted for within our system. We initially started with quite a few software glitches because we didn't anticipate the volume of observations for some of our patients. The time that it would take for some of our observations to be loaded, for screens to be seen. And these are all things that we've worked through, and we now have really quick load times. We have sufficient observations for our patients to just see what that pattern of observation has been for our patient, or what their pattern of normality has been. As Gillian's already said, some of our hardware options, we expected Gillian to go big in hand and cap, looking for some money for lovely handheld devices. We let our staff trial them, and they hated them. They were too heavy, they couldn't see the screens, they didn't hold their charge. And what actually worked for us was using the computers on wheels that the staff already used. It was already part of their system for HECMA, it was already part of their routine, and this just fitted really seamlessly into that as well. We had to make sure that the system that we built was incorporating all of our current standard operating procedures around news and escalation. So we worked really hard with the track team to make sure that all of our safety systems that we already had in place when we had a paper-based system were still there when we went to an electronic system. We didn't want to create a system that was not as safe for our patients as our paper-based. I think confidently we can say that we now have a safer system within NHS Lothian. We had also our early adopters, people who were really keen to play with a new toy. They found it in areas that we hadn't gone out live in, which showed that we had created a really easy to use system, and we had to hold them back until we went live in their own areas to allow them to use it. But it was actually one of our pushing drivers to roll this programme out at a quicker pace than we were anticipating. I think that's really fair to say. But the staff were also keen and also on board with the changes that we were going to make. Where we go next with it is we now have a really, really good system that tells us really, really good things about our patients and about our deteriorating patient system that we have in NHS Lothian. Within the measurement framework, I'm sure you're all very familiar with it, there is a package around cardiac arrest reviews and trying to review over 95% of them. We took that on and we struggled with it because access to paper news charts was really difficult. You were chasing notes from reviews from cardiac arrest that happened at the weekend when you weren't on shift. They had gone to their secretaries. It's really, really challenging to find these. But it's now transformational for our cardiac arrest reviews. So the last 2 months on the sites that we've rolled out on, we have achieved 100% cardiac arrest reviews on the 2 acute sites. And we will hopefully continue that on the Western site as we roll out over this next month. It also opens up scope for us to do work within medical emergencies, which is an area that we haven't had much understanding of just now. We have an oversight of our numbers in Lothian, but it really allows us to dial down deeper into the medical emergencies and really measure the pattern of deterioration that's seen by our patients on the wards. We have this lovely system. We need to get some lovely data from it, as I'm sure you all agree. The data with the story from a cardiac arrest review or the medical emergency review is what's going to transform and buy a lot of engagement in our project. M&Ms, the site teams and the local teams, they can now see all the observations that we can see, making it a lot more cohesive in the review of a patient. You can really follow the patient narrative from entry point into our system to point of event that's happened. And as we say, the power of the data, we can make huge improvements if we know where our data sits. We can now identify point of deterioration, point of escalation, point of recognition, all of these points in our system that we have to have as measurables. We can now identify to really drive improvements and measure the impact of our improvement in the future. Where we go next, as Gillian said, we're rolling out or scoping to roll out into other patient groups. Paediatric is going to be our next target area, and they're very excited about joining us on this journey. We're looking to integrate those overview boards that you've seen into our site huddles to make it a safer system. We've had really good learning from our colleagues in Fife about how to use those overview boards, and it's something that we really like to look at and know the end. And we're going to look at also how we can preempt deterioration and how we can respond to that in a quicker way. The data world for our deteriorating patient has really opened up to us, and as one of our colleagues said to us, we're now in a transformational period of our data and a period of enlightenment, which was interesting words to hear from our colleagues, but it's really where we're heading now. It's opened up our project, it's opened up our scope to make our patients in NHS Lothian a bit safer. So we've got some acknowledgements here. Lots of our e-health team, as Gillian's already alluded to. The quality improvement team have been key as well in that. LACAS team and all of the NHS Lothian staff, especially Kenzie, Ward 208, who started with Model Ward, the staff in Ward 206, who let us do our first acute trial as well. It's really, the project is only where it is now because of all those people that have helped us along the way. And certainly Nikki, that's sitting in the corner there, has been very vocal. I'll open it up now to Gregor and Gillian for a question. That's okay.
Thank you for that. Team Lothian, I think that's an incredible piece of innovation and it's now laid the foundations for good improvement work. And really having such a large health board, electronic digital is key to having that overview. So just to open it out to the floor, are there any questions for any of the team from Lothian or online?
I think that is something Gillian knows and work together on that.
So if you don't know, just for our online audience, so they can read the questions.
Gillian and I obviously work together and worked with Gavin as well. It's the patient track team here in NHS Fife. So patient track is obviously embedded in NHS Lanarkshire. In Forth Valley, we're currently at the last stages of the business case going to programme board release that hopefully will get approval. What we've had some trouble with is getting some commitment from InterSystems around getting the same visualisation as Lothian. So what we've been shown is very basic looking compared to what you guys have got. So it's, you know, just how do we get around that? Is it cost? Is it negotiation? Is it what's the best route forward?
I'm not exactly sure, Cam. If I'm being really honest, I wonder if it's just worthwhile engaging with Martin Egan as our e-health director. I think having a conversation with Martin. Obviously I landed in Lothian when it was, you know, and we've got a phenomenal relationship with InterSystems. and to be able to build and do what we've done. But there isn't any reason why that shouldn't be and couldn't be lifted and dropped. Why would we then not do that? That just doesn't feel right, you know.
Yeah. And the beauty of the network is obviously learning from other health boards and taking that to our own health board and saying this is what's worked elsewhere. Here is the evidence that that works. Certainly, you know, the enthusiasm is quite evident, and the excitement and how you've taken people with you along the way has been quite phenomenal. I can appreciate your software glitches having sort of co-produced the e-digital app, but those early adopters are really important. Is there anything else around here? No questions? Yeah.
Okay. Hi, I'm David Craig from NHS Glasgow and Clyde. I won't tell you where we are in Glasgow just now because we're far behind you. But what I was interested in is how does your track care system link into your risk management system? I assume you maybe use Datix as well, but does it link? And just on the point that Gregor made at the start, that there were so many incidents that were being brought up that you saw that it was around the early warning score and capturing that. Are we seeing that completely fall away now, or is it still? Are you still seeing that?
We do have Datix, yes, as a risk management system. They're not obviously linked, but actually, you know, the data that we get out of the system really supports us to do some of that risk and governance part of it. Some early data then that I got a report on Friday, 6 months post-implementation for the Royal Infirmary, so obviously that's our biggest site, and just some high-level data. So calculation of news score was an issue for us. So we've gone from being 66% compliant to 99% compliant on that alone. The other big factor for us was overnight observations that were missed, and I think that's the same everywhere. The lights go on in the morning, the patient's been sick overnight and there's no observations. So 76% of inpatients in the Royal Infirmary had missed observations this implementation, and that's dropped to 47 now. I think the good news about all of this is we actually know where the improvement is because we've got the data that supports it, and we can really do targeted improvement in the areas and around the issue rather than just being a bit blind to it all. Yeah.
Thank you. Can I just highlight a couple from our online audience as well? So Tim Sherman NHS is really excited to see the work developed in paediatrics. You mentioned raising with Fife about their overview boards. How did you engage with other boards to learn from their experience with EOBS? I'm interested in what that collaboration looked like.
So I guess this is a bit of it, isn't it?
Excellent question.
Doing this today is definitely about how we collaborate, learn, how we share, and I think, you know, building that, you know, we're a small country, we should be able to do that even more than what we've done. Yeah.
Probably just add to that. I mean, I suppose we're thinking about the next phase as well. I mean, we know with the SPSP measurement framework, our focus will be, I think, increasingly on the response to deterioration. And we know, like colleagues in NHS 5 have been looking at a trigger time for the time the news goes up to the time that the patient gets to get to care. And again, we can look at that now because we have the news on track system.
It's really opened up many possibilities moving forward. The other question is from Donna Calder. Were there any near misses? And what was the learning at the early implementation of EOBS?
So I wouldn't have said there were any near misses. I think we did the testing that we did, particularly around the simulation, was critical for us around that. Building things and viewing it on the test part of track before we then dock it into Alive, and all the testing was done at that point before it was ever put into live. I think the early learning for us was definitely around the hardware, I think we genuinely started, well, I started in this journey having my mind that we would have a handheld device, 3 or 4 in every ward in Lothian. And actually when we got to the point of doing that testing and teams were away using different types of devices, small pocket size to, that was, so I think for me that was a big piece of learning.
Certainly coming on your site visit, we can appreciate that. I think the other thing is obviously when you work with e-health, your level of governance is a whole new level, and it's test. Okay, I think we'll be one more. Yeah. Time for one more. Yeah. Okay.
Hi, I'm Liz and I'm from Bradford. So I'm really interested in the work that you're doing. So we've got something, I might say it's really flash, but it's been built by GE. We have patient deterioration trial. I'll show it to you. But I'm really interested in around your oversight boards. So we use our, which looks very similar, and we'll use it at hospital at night. So it's when they sit down at that 10 o'clock handover to be able to identify who our sickest patients are around the hospital. We've got BRI, Bradford Royal Infirmary. It's a very sprawling site, and we've got a couple of junior doctors. So it means that they're not. We've done some really interesting work around quality improvement, just measuring footfall, how many steps they're taking overnight to try and go and see their patients, and actually sort of been prioritising where they go and what they do. So we've been using it again, as I said, at hospital at night to really drive, again, sort of understanding where our sickest patients are. I just wondered if that's something you've thought of.
Yes, yeah. Hospital at 19. Does use, I think that overview board is important. Karen, remind me, is that, would that be patient track? I think you've probably got, is it?
We linked in with that around the command centre work. So
Yeah, so you've got a command centre.
Yeah, okay, yeah. So,
Interesting.
I know, definitely, it's good to just hear that, isn't it?
Okay. And I think just Gavin. Gavin from AH's fine.
I'm Gavin Simpson and from 5. Congratulations, that's a massive work to build it from scratch all the way up to such a massive health board. And I think having different strategies about detecting, communicating, deteriorating patients only makes the environment healthy, because it drives innovation, it keeps it dynamic and keeps it progressing. And it means that as more and more people come on, more collaboration we can have. And I think it will just make things stronger and stronger, which is phenomenal. I heard the word enlightenment there, and it said lightning, and I never heard it before, but it is just that amount of data you get. You suddenly open a dark box, and all this information starts coming out, and you start having light bulb moments where the problems are that you just had no scope to understand before. And even though we've been doing this for a while now, I feel that we're only halfway uphill. And every day we're learning new problems. I think somebody said that knowledge is like a sphere, and the bigger it gets, the more exposure to the unknown you have. And this is like that. And so I think as more people start doing this, we're going to be able to increase the pace of change, which will make things better. So incredible. Well done.
I think we are now moving on to our activity session. That's right. So we're going to break it into groups, and we're going to help facilitate that. So having heard such an inspirational story of innovation and laying the foundations of improvement work, consider what you feel may be the game changer in your current deteriorating patient QI work. We have put up a few questions here just to help you sort of frame your thoughts around what's happening in your area, what's happening now, but actually more importantly, what's going to happen in the future. So what will create the conditions for this change? Who are the key stakeholders to start? Who are the key stakeholders to complete the change? And what benefits will this change? Importantly, the impact to patients and staff. Okay, the session is going to be, I think we're going to use a 4 flip chart, is that correct? You're right. And our online team will have a whiteboard online as well, and some facilitated discussion there.
So probably introduce yourself to people you may not know in your own table, start thinking about those questions, come round back to you and prompt further discussion. And when you come to some solutions, start putting them up on the boards you see around the room, and we'll kind of bring you together with kind of 5-10 minutes to go, and we can talk about what you discussed. It doesn't have to be relating to news on track. It could be some other aspect of patient deterioration you're challenged with, whether it's sort of response, future care planning, etc. Okay.
So there's 15 minutes discussion on the table, and then we'll bring it back for another 10 minutes discussion thereafter.
Hi everybody, my name is Tim Shimon. I'm an improvement advisor with HIS. I work on the SPSP paediatric program. I'm just stepping in just here, just to apologise for any technical difficulties that we're definitely having. So the idea for this breakout session was that there was going to be a poll, which has now launched the correct poll. That's the one which is what will create the conditions for the change. And then for that to also populate onto a whiteboard, and for us to have some time to use the whiteboard as well to kind of get our thoughts out there. So I suppose Mary's just letting me know that there's been some issues there. So I guess in order to just sort of save some of this breakout, if you could pop any thoughts or in response to those questions in the chat, then when the room reconvenes, we'll have something as an online group to sort of contribute. If there's any chance that you've had a chance to think about those questions, that would be great. Thank you.
So thank you very much. Hope you had some fruitful discussion. Apologies to our online audience. Thank you, Tim. I think has been in charge, and our whiteboard didn't this year, unfortunately. So we're going to, I think, take it back to Dr. Ray McNeil, who's Kilroy still, a few minutes ago, he's roving Mike. And we're going to go around the different questions and see that we start with what will create the conditions for this change. If you're online, could you please post any comments, feedback into the online chat? And again, apologies if that's not worked.
Thanks very much, Lindsay. So yeah, I'm Jeremy Cowell of this piece. What will create the conditions for this change? So we've got a few things on this board here. Data. I think data is very important. If we think about the sepsis driver that is about to launch, that is underpinned by new data, new national level data, suspicion of sepsis data. So we can see that that is going to be hopefully be a launch pad for us to do improvement work around the deteriorating patient with sepsis. Organisational stories. I think that again can be a big enabler, can't it? We've seen that in UK wide. If we look at things about Marflutol, etc. in NHS England. A once for Scotland approach. So I suppose I'm a bit nervous about this, because as we all go away and develop our own electronic observation system, but I suppose there are areas where we are trying to do a once for Scotland approach. If we think about national future care planning, we've got NHS Scotland and Scottish Government buying for that. As we move towards a digital tool for future care planning, we think about the digital respect. And I suppose there's also the National Tech Users Group as well. So I'm standing next to this table here, hovering slightly over to beside my place. Steve, how would you summarise the National Tech Working Group? What were we trying to do there?
In the spot, excellent. I think what we noticed is that PEPS feeds off this work. It all goes together, and obviously the logical that lives in my head has all this working perfectly. And if it works in one place, it should work in another place. Exactly what we've been chatting about at the table with the news work. We've seen different variations, but there's a lot of similarities in the. And this part of the group is to try and bring that together, get a national treatment escalation plan that we can all work off, and then work on the implementation of that. So that'll feed into the future care planning. So a community ACP future care plan, be it Respect, be it something else, and then something for the acute hospital that has that more granularity of detail that the junior doctor in the middle of the night, the nurse in the middle of the night needs. But that's a once for Scotland approach. And I think we could be really ahead of the game I don't see that happening anywhere, and if that could happen in Scotland, that would be excellent.
Thank you very much. Okay, and then I suppose
Just, I'm going to bring in our online audience as well. Thank you for posting some comments. So just again, what will create the conditions for this change? Motivation, interest, staff on the shop floor, explain how it could benefit them and their patients. Again, coming back to the impact on staff and patients. Ward managers and staff on the shop floor, comms, better outcomes for patient and families. A lot of this again comes back to person-centred care, patients and families. Identifying early adopters.
Thank you very much. And then I suppose the next bit we want to talk about is who are the key stakeholders to start. And I suppose if we go into this board here, what have we put up? Well, finance is always going to be up there, and that is a tricky one right now for all of us, isn't it? If we look beyond finance, I think the interesting ones we picked out here are, let's see, we've got them, systems users, nursing leaders, and management as well, and medical leaders. And I think certainly in our project in NHS Lothian, as you heard from Gillian, we got excellent nursing leadership from Gillian and her team, as well as having that medical leadership. That was really useful to us. But the other big one that we've got here are data support and e-health. And I think whatever we're doing right now, whether it is a response to deterioration, the recognition of deterioration, the National Tech Users Group, e-health plays a part in that, and having them on board and the data support that gives us is really crucial. And the other thing we put in the stakeholders are patients as well. And I suppose that is key, because they inform what they wish. And I suppose if we look at patient deterioration stuff, UK-wide again, and if we get back to that example of Martha's role down south as well, that has been delivered has been really driven by patients and their families and what they want. And so that's mainly what we've got on the board there in terms of key stakeholders to start. Lindsay, next.
I think everything online just mirrors what's been discussed in the room, and that it has to be multidisciplinary, involve patients and families, and it has to include co-design. So number 3, who are the key stakeholders to complete the change?
So
we can keep posting comments online.
So this one I will hand over to my colleague Megan on that side.
Thank you. So I guess what we're seeing here is that while you've got your team and you're somewhere along your patient journey, the people who started with you might not be the people who you need for the next bit. And what we're seeing in this side is much mirrored from the beginning. So a big emphasis on patients and families, all staff, and including our non-clinical team, so management, ops management, IT, educators, and back into the external data support. And also thinking about transient members of our team, so people who are not maybe part of our core team, but who actually are delivering a lot of the care. And then into benefits about the change we'll have for patients and staff. So no major surprises here in terms of avoiding harm, making things safer for our patients, reduction in cardiac arrests, but also reduction in avoidable mortality, reducing bed days, thinking about the financial side effects, beneficial. And then thinking about actually our staff and the psychological safety for them, and them having that permission to make changes, having more education which can build knowledge and confidence and around their QI work, and also thinking about it from a whole system approach with a realistic medicine underpinning through everything.
Thank you very much. We'll move on. So just thinking about next steps, hopefully when you had your breakout session there, you're engaging with lots of different professions, individuals and health boards, that you've got lots of ideas in terms of how we're going to move forward. Although we're saying this is a sort of end of collaborative celebration event, the work is really just beginning for many health boards. And hopefully we can continue to use these questions to sort of frame, what is it in your area that is an area of either strength or weakness, and how that can be developed. Is there any other comments at all from the floor? No. Okay, so we're going to discuss the afternoon session. So we're going to go for lunch now, which is going to be 50 minutes, maybe slightly less because we've gone over. In the afternoon, we're going to welcome you back at 1:25. Eddie Doherty again is going to introduce the afternoon plenary, which is going to be focusing on deteriorating patients. I'm going to give a brief intro before passing you over to our team talking about patient and family worry and concern. And I know we've talked a lot about Martha's rule and we'll visit that. And it's really a very interesting area of discussion. And then we'll have a second breakout session. So everyone in this room will be obviously going off to another breakout session. So for those online, if they just follow the link below in the chat box to return to the main plenary. Thank you. I did it.
Because